Morning, everyone. Apologies for appearing in my scrubs. Um, I'm going to be talking about biopsy strategies in prostate cancer, and hopefully, we can discuss and raise some issues that border around something that's quite important to the care of our patients. So, there are a number of things to consider when seeing a patient or thinking about biopsies and whether patients should be biopsied. There are patient characteristics, procedure characteristics, and then other indicators. The patient characteristics, you're thinking about patient's age, PSA, examination findings, volume, previous biopsies. Operator characteristics involve whoever is doing the biopsy, is it a radiologist, is it a urologist, what level of training, and so on. What route are you going to use? You're going transrectal, transperineal, transurethral, number of cores you plan to take, where you plan to take the cores from, and then other things, other adjuncts that could help decide whether or not a biopsy is indicated in a particular situation. Talking initially about PSA, usually most patients come to us because of a raised PSA, and even if the the examination is benign on the DRE, most of these patients still require a biopsy. And the PROTECT study looked at the value of repeating the PSA prior to deciding on biopsy. And what they did basically was, patients had a second biopsy just before second PSA just before their biopsy. So the decision to do the biopsy was made based on the first PSA. And then they looked at patients that had 20% or more drop in their PSA values before biopsy. And basically they stratified them according to the initial PSA. And they found that in men that are 60 years or less, there's quite a significant decrease in your risk of cancer if you have a 20% or more drop in your PSA. So this sort of highlights the importance of not proceeding to biopsy just on one elevated PSA. I'll talk very briefly about prostate imaging just because most of the modern biopsy strategies involve some sort of imaging. So you have a standard truss which is done transrectally, shows where the prostate is, guides where the biopsies are going to go. You have advanced truss techniques that involve elastography and histoscanning. And you have MRI, which is sort of the new and emerging thing that's guiding the way we're going probably in the future. Thinking about the strategies, I think I mentioned this already. Do you want to go for a template biopsy? Do you want to go for a targeted biopsy? Are you going with the fusion technique, cognitive fusion, or is it going to be a ultrasound fusion? Are you going to use standard truss, and what sort of truss? Not everywhere or not every center has a histoscanner or elastography scanning machine. So what you're going to do is going to be based on what you have available to you as well. If a patient has a negative biopsy, are you going to do an extended truss, a saturation, a transurethral, or a template biopsy, or image-guided, MRI-guided targeted biopsy? So ultrasound was first reportedly used for prostate imaging in 1963. It's able to capture images in two planes. It was usually thought that cancers were hypoechoic on ultrasound, but we now know that some or many tumors actually are isoechoic or even hyperechoic. For those who are well trained with ultrasound, they can detect extracapsular invasion and seminal vascular invasion as well. Elastography again builds on ultrasound technology, but in addition to the ultrasound images, it also uses the compression characteristics of the tissue, and based on a software program, they're able to sort of predict whether or not a particular area is more likely to have a cancerous cell, just because in theory tumors are more densely packed in terms of the cellular density, and so there'll be less elasticity in areas where there are tumors. Histoscanning is a proprietary technology that basically uses information that's already available with a normal ultrasound, and it's called backscatter. And basically the way ultrasound waves are reflected back from the tissue as it passes through is used and passed through an algorithm, and it's used to predict whether or not there's likely to be areas where there are tumors. MRI seems to be what's sort of mostly or more widely utilized these days in terms of getting anything more than just an ultrasound for imaging the prostate. So there's what we call a multi-parametric MRI, and the basic components of that are T2, a diffusion weighted, and a dynamic contrast enhanced sequences. There's also the spectroscopy, which is not yet in clinical use, but it's being worked on. There's research going on trying to determine how it can be incorporated into prostate imaging. The PIRAT scoring system has been devised initially in 2011 and a revision in 2015, which sets out lots of parameters for the radiologist in terms of what sequences to do and how to report them, so that there's uniformity between centers in terms of reproducibility and transferring data, and also for urologists in determining whether or not to proceed or recommend for a patient to proceed with biopsies. The PIRAT score gives the indication, with 5 and 4s being more suspicious for cancer, 3 intermediate, and 1 and 2 less so. A few differences between PIRAT version 1 and 2, which I won't go into too much detail about. In terms of what's happening with in terms of a T2 sequence, basically the magnets are measuring the time taken for spinning protons to return back to their phase after exposure to the magnetic pulse, and that releases energy, and that energy is used to calculate and run through computerized algorithms, and images are generated. Malignant prostate tumors have low T2 signals, and T2 gives quite good anatomical staging of the prostate. The diffusion weighted images are a measure of movement of water molecules within the tissue. Again, because tumor cells are thought to be more densely packed, there's going to be less water movement, and so a tumor has a low diffusion weighted signal. The dynamic contrast enhanced sequence is measuring how fast contrast washes in and washes out of the tumor. So because tumors are thought to be more vascular, then contrast is thought to wash in and out quicker because there's more vascularity to it. Talked a little bit about spectroscopy. Basically, it's measuring the relative concentration of several metabolites within the prostate tissue. A number of studies have shown that prostate tissue has higher concentrations of one metabolite or the other. They haven't quite worked out which is the best to look at, but I think probably in the next few years it might come on board as part of the MRI sequences for clinical use. So if you decide to biopsy a patient's prostate, you want to go for digital biopsy, transrectal ultrasound guided biopsy, transurethral biopsy, or template biopsy. Digital guided biopsies was how it all started. Large studies have shown that up to 35% of patients have an abnormal DRE. Patients with cancer have an abnormal DRE. So in theory, you could feel where the tumor is, you could biopsy it. And even with patients who've had 8-core systematic biopsy, they haven't really showed much yield difference between TRUS and an 8-core systematic biopsy. However, digital biopsies are quite unsafe. It's a lot of variability. Anatomically, you're not really certain where your needle is going, and then the injuries are a risk. Several groups have have described different ways of reducing the risk of biopsies, but I think in the modern era and with the availability of ultrasound and other imaging, I don't think digital biopsy still has a role. If a patient is not well enough to go to an ultrasound or biopsy suite, then you have to think about whether or not they should really be having biopsies at all. So standard truss biopsy is the most widely used method for obtaining biopsy tissues. Various strategies have been reported, ranging from 8 to 14 cores. Studies have shown that increasing number of cores increases the yield, but usually above 12 is not significantly more increased yield. Therefore, 10 to 12 cores are recommended generally. The weak side of this strategy is that potentially 30% of tumors in the anterior part of the gland could be missed. There are also variations in operator outcomes or operator yield in terms of biopsies. This is something that's not usually discussed widely or talked about, and again, we know that some centers radiologists do it and some centers urologists do it, and there's always a bit of banter between urologists and radiologists over who does biopsies better. But again, within the PROTECT study, they found that different centers involved in PROTECT had different yield in a fairly homogeneous population where you wouldn't expect that difference to be due to a different prevalence of prostate cancer within the populations. So it's something to bear in mind that training and technique is important whenever you're doing a biopsy of the prostate. So if a patient has a first negative biopsy in the face of still elevated or rising PSA, what do you do? Traditionally, in the past, these patients were subjected to 2, 3, or even more biopsies, and studies have shown that the more biopsies you do, the yield gets less and less and less. So you have to question whether the old strategy of doing repeated truss biopsies is really justified, especially in this day and age where there's other approaches on board now. Looking at where tumors are found on repeat biopsies, seems apparent that quite a few or majority of these tumors tend to be in the anterior part of the gland, more so around the apex, and these are areas that are not easily reached by transrectal ultrasound biopsy. So if a patient has a negative biopsy, I think it's probably not justified subjecting them to repeat biopsies without thinking about other strategies. Extended truss biopsies is a slightly vague, it's not very clearly defined what is meant by extended truss biopsies, but basically it just means taking more than the standard 12 cores and also trying to include some transitional zone cores in the biopsy. One study has looked at an optimal biopsy strategy that they think detects 95% of cancers, using a 24 core as a gold standard, and then looking at how many cores they had to take from each patient in order to detect at least 95% of the cancers present. And they've come up with an algorithm that shows basically in summary that if there's positive GRE, 10 cores or less cores are necessary to pick it up, which is quite intuitive. And a 14 or 16 core was required to pick 95% of tumors in patients that had negative DREs. Saturation biopsy also is not very clearly defined what is meant by saturation. Usually means that more than 20 cores taken again with sampling of the transitional zone. Sometimes it's done under local anesthetic, sometimes under general anesthetic, and they could either use the transrectal or the transperineal route to achieve this. A a look at the yield of various studies looking at saturation biopsy detection rates. Basically, from what I can get from it is that the more cores you do, the higher the detection rate, and also the larger the gland size as well tends to give you more cancer yield on a saturation biopsy. This is just running through the adverse events of trust biopsies. Again, we know that most patients experience pain and discomfort, get a bit of bleeding, but sepsis seems to be the most serious and most important of all these adverse events. A lot of patients, especially in areas here or areas where patients are coming from a long distance to have their biopsies, they might end up going home, so far distance from where they've had their biopsies. They might feel unwell. They might show up in a center or at a doctor's practice that doesn't quite understand the risks, and they might get undertreated for their post-biopsy sepsis. So it's important to counsel patients about what to do if they do feel unwell after a biopsy, and to go to a center, preferably where they had the biopsy, or a center where they're used to dealing with post-biopsy complications. They can recognize it and treat it appropriately. Transurethral biopsies are sometimes done in patients who are undergoing saturation biopsies. So in addition to taking more transrectal cores, they take some transurethral samples as well. Again, that increases the yield just simply because you're able to get tissue from the transitional zone that you wouldn't normally be able to get from the transrectal route. Patients, again, with more tissue resected tend to have a higher yield of cancer in them, which is not surprising. There's a high morbidity from it, high rate of urinary retention, 30% versus 17% of patients who had just saturation biopsies. So the addition of the transurethral swipes increases the risk of retention, of readmission, but surprisingly not of sepsis. Transcranial template biopsy basically is based on the brachytherapy grid, which has 5 millimeter intervals, and this grid is placed in the perineum after it's cleaned and prepared, and biopsies are taken usually under ultrasound guidance through each of the grids. So there's roughly going to be a 5 millimeter space between each core. So if a tumor is missed, it means in theory that it's less than 5 millimeters in size. This usually has to be done under general anesthetic. I think in some centers they've explored using, just doing it on a local with some sedation, but I'm not aware that many centers are doing that. I think most centers tend to do it under general anesthetic. The main difference really is, like I said, you can sample more tissue, but the sepsis rate is much less because you're going through basically a much cleaner route than a transrectal route. Some of these patients have it or have their transperineal biopsies with a prior MRI available, so the operator can either do a fusion, ultrasound fusion method, or cognitive method of registering where any suspicious areas in the MRI were. So when the transperineal system was being developed by Basel and colleagues, they looked at some patients who were being assessed for focal therapy, and they assessed the value of the template mapping biopsy in detecting extra cores that were missed on the initial transrectal ultrasound. And And they found that the transperineal additional biopsies that they did helped to detect quite a number of tumors that would have been missed if they hadn't done that. And they looked at whether or not these additional samples that were obtained would change the management of the patient. And they looked at several factors, whether the truss detected unilateral tumor, which could have been suitable for focal therapy, and now the transperineal detected more tumor on the other side, which probably means that they can't have the focal therapy they were going to have. Is there a higher Gleason score than what the truss biopsy detected? Is there a sample in the midline? Again, in the midline, it would be difficult to treat with focal therapy because of risk of injury to the urethra. Is there a neurovascular bundle involvement, or any one of these criteria? And they had about 76% of patients that had their management changed just by the addition of transperineal biopsies to the truss biopsies. And this is a group of patients who were being considered for focal therapy, so it's a select group of patients. There have also been studies sort of modeling the yield between various techniques of transrectal ultrasound biopsies versus transperineal. So what they did in this particular study was they took 107 radical prostatectomy specimens. They obtained the pathology from it, detailed pathology saying where all the tumors were, and then they modeled the prostate in 3D with all the locations of where the tumors were based on the pathology results. And then they simulated taking either transperineal biopsies using the 5mm grid or various transrectal biopsy strategies. And they found that both for tumors less than lesions, less than 5mm, or those between 2 and 5, and those less than 2, that the transperineal modeling strategy detected outperformed all the transrectal ultrasound strategies that would have been employed. Some groups have actually tried to combine transrectal ultrasound with transperineal. The rationale for that being that the transperineal is better at sampling anterior parts of the gland, whereas the transrectal is better at sampling the posterior aspects of the gland. Depending on the patient's morphology, sometimes you might find that the transperineal needles can't get to certain parts of the prostate, usually posterior, or sometimes if the prostate is gone sort of anterior behind the pubic bone, the transperineal needles can't get there. So transperineal biopsies supplemented with transrectal biopsies were analyzed by this group, and then they worked out a total of 26 scores and tried to work out the proportion of transperineal biopsies versus transrectal biopsies that gave the best yield, and their analysis came up with a combination of 14 transperineal biopsies and 12 transrectal biopsies to detect or to give them the highest cancer detection yield. Now, this particular study did not use the 5mm grid pattern, so the 14 biopsies that they took transperineally, I wouldn't really know how they'll decide exactly where to place the 14 needles without using a grid. So MRI is becoming more and more utilized in the prostate cancer diagnostic pathway. So we talked about how the MRI works. If you then find any suspicious lesions, and rather than doing systematic biopsies, you target those lesions specifically, you find that there's a higher yield of cancer from doing a targeted biopsy. So you have 30% yield of cancer per core versus 7% with systematic biopsies. You're able to rule out some men who don't need biopsies. You avoid biopsy in a number of men who would ordinarily have had biopsies. And the theory behind that is that the MRI, based on the PIRAD scoring, flags up tumors that are more likely to be clinically significant, and that's using a definition of greater than 5 mils or any Gleason 7 tumors. So the MRI targeted biopsies improves the yield and reduces the number of men that need to be biopsies. There are some downsides to it, and basically some men have their cancers missed. Most of these men are men with insignificant cancer, but 2.3% in a particular study, pooled analysis, had clinically significant cancer missed. There's no prospective validation yet available, so all this is still in evolution, and as data comes out, is going to be affecting practice and what we do. So looking at the detection rates for MRI guided biopsies, again, in keeping with how the PIRAD scoring has been designed, the higher the Gleason score, the more likely it is that the cancer is going to be detected on MRI. Also, the higher the volume, the more likely it is that the cancer is going to be detected on MRI. This study looked at patients who had an abnormality on the ADC sequence, so they had a low ADC area, and these particular areas were targeted. They also had an 8-core systematic biopsy and 4 cores from the suspicious area. There are 890 men who had an abnormality on the ADC, 558 with no abnormality on the ADC, and those 558 with no abnormality just had an 8-core systematic biopsy. And they used a transrectal route for their study. And I've just highlighted 2 boxes in red and in yellow. So in red are the patients who had both the systematic and the targeted biopsy versus those who had just systematic. So it's just basically showing how the ADC abnormality is positive in a very high proportion of patients, and that leads to higher yield of tumor in the patients versus patients who don't have any abnormality on the ADCs. Sorry. Mm-hmm.
That previous paper explained what they did with the patients in the yellow box that had a PSA over 20, but the 75% where no cancer was detected.
Yeah, I don't know specifically what they did with that subcohort, but I don't know. But if they've had PSAs that are that high, possibly they'll get rebiopsied or have a repeat MRI at a certain interval, 6 months sometimes, and then decide. So it's still not known what's the best rebiopsy strategy. I think it's accepted that based on availability of devices and so on right now, that most men will still have a standard transrectal ultrasound first. Question is, what do you do if that comes back negative and there's still clinical suspicion of cancer? So this study has looked at repeat biopsy strategies using either a transperineal template biopsy or a saturation biopsy or an MRI targeted biopsy. And basically what is found is that there was no difference in yield between the transperineal and the MRI guided biopsy. and they were both better than just a saturation ultrasound guided biopsy. Again, going into more complications. So this is a pooled analysis now of systematic review of several papers that have reported complications from prostate biopsies. And you just list them in descending order of frequency. Hemospermia, hematuria, rectal bleeding, prostatitis, and so on. Fever, again, features there. And we do quote a figure of about 1%, which is in keeping with the international data that's out there. Urinary retention, worsening of LUTs. It's not mentioned in this one, but a lot of other studies have mentioned it. This I found the most difficult to actually get any data on that could be useful. It's just trying to look at the cost of all these different biopsy strategies, and it's difficult to assess because of different sort of purchasing agreements between different hospital systems and different suppliers. Some people get some equipment on loan or for free, so it's really difficult to assess. However, using just UK figures based on hospital billings, trust biopsy costs about £500. So basically, the hospital gets a remuneration of £500 for a trust biopsy. A template biopsy, transcranial template biopsy, costs about £2,000. But as far as I'm aware, they're still not paying £2,000. They'll still pay you, or pay the hospital £500 because, as far as they're concerned, it's a prostate biopsy. So still a lot of negotiation happening between the hospital systems that do template biopsies to try and get more remuneration for doing template biopsies than they'll normally get for a trust biopsy. Obviously.
Anesthetic costs.
Yes, yes. So exactly.
Much more than
Pathology, because we get about 36 to 50 cores from a transcranial biopsy. But this study looked at the cost effectiveness. Basically did a modeling study, and what's the outcome, or what their conclusion was, is that even though the MRI, following the MRI targeted biopsy route, is slightly more expensive in terms of per patient, because less patients are going to end up being biopsied over time, there's going to be a net saving down the road. They did admit to some limitations of the study, including paucity of data from different sources and not being certain about certain costs, for example, the pathology costs and so on.
The other thing that doesn't make sense here is you're going to do an MRI, you're going to add the trust on top of that. So does it make any sense to be at the same cost as a trust? If anything, it's going to be trust plus the MRI. It's going to be at least $1,000.
So the savings are
very
Yeah, the savings will come down the road because, for example, if a patient has one, in fact, actually, the whole idea is to try and avoid the trust. So patients will have an MRI first, and patients with no abnormality will be avoided. It will be save the biopsy.
But you have to factor in what proportion of MRIs then lead to a trust biopsy. So what are the proportion of MRIs that allow you to avoid a biopsy? Do you know that?
So
if you have a PSA, elevated PSA that usually directs you to a biopsy, under what proportion will an MRI save you having going on to a biopsy?
So the answer is not out on that yet.
So how can they actually?
It's just modeling. So these are all modeling studies where they.
But what do they model that fraction?
They're modeling just the multi-dimensional MRI as a cost, separate from the trust fund.
Are you saying that you're doing some MRIs and not biopsy on the basis of the MRI?
So not within clinical practice, but there are clinical trials where they're doing pre-biopsy MRIs, and then they're going on to do biopsies, and then they're following these patients prospectively to then down the line see how many patients based on the pre-biopsy MRI would have been saved biopsy and treatment over
So
time.
this is the sensitivity of MRIs.
Yes, and the negative predictive value. So I'm just going to talk a little bit about MRI ultrasound fusion. And that's just because for MRI targeted biopsies, that's sort of the standard. There are different ways to use MRI for your biopsies. You can either do what's called an in-bore procedure, which is where they use non-ferrous needles. The biopsy is actually done within the MRI suite, so you're scanning in real time and you're targeting your biopsies to the lesions in real time. This is still not available in many centers because it's time consuming. It takes up the MRI scanner. Most centers have a lot of demand for the MRI scanners, and to have a radiologist there for over an hour doing biopsies is just not feasible in many centers. And there's the cognitive registration, where the person doing the biopsies has seen the MRI scan, has mentally noted where the abnormalities on the scan are, and goes for those areas in the biopsies. Or you have the fusion technique, where the information from the MRI is loaded up into a software, then the real-time ultrasound is also loaded up, and then you could target based on your real-time ultrasound to the areas that are highlighted on the MRI. I haven't been to see one of these yet, but I will. There's a number of systems that are available. This is just a diagram showing what some of the systems look like. Here in VGH, we're using a Urology system, which I don't know the exact details of how it works and the specificities and sensitivities of the system. But our radiologists have told me that this particular system has not yet been approved by the FDA. These slides, by the way, were lent to me by one of the fellows, Dr. Emily Pang, so I'm grateful to her for letting me show these. And it's just showing the inside of the suite, how the patient is positioned, is under local anesthetic, and that's the operator looking at the MRI scan and using the ultrasound real time to fuse with it and deciding where to place the biopsies. In our center here in VGH, they're still doing systematic biopsies along with the targeted cores. And this is just a summary slide of the experience so far. They've done over 350 patients, and so far they're showing that the fusion system is detecting more of this higher yield than just with a systematic, but would have been detected with a systematic strategy of biopsies. A number of things to consider. Again, the original MRI that was done is going to determine the quality of everything else that you get down the line. So it's important that the MRI sequences are taken based on widely accepted guidelines, especially if it's not going to be the same person who's reporting the MRI that's going to do the biopsies. Prostate MRI obviously still evolving, things are still changing, the PIRAD scoring is still in evolution. Whether or not spectroscopy is going to come in, there's so many variables that are out there that are not yet answered. Looking at future directions for where biopsies may be going in the future. As with anything, new technology keeps coming out, and smart people all over the world are trying to incorporate these technologies into the biopsy pathway. This is something called an e-finger, which has been being developed in Edinburgh, which basically it sounds similar to what the elastography machine does. So it basically uses digital technology to assess the stiffness of prostate tissue to determine whether or not a biopsy is necessary. Again, I think this will be used in clinic to help to decide whether to refer patients or not to biopsies. I mentioned already MR spectroscopy. The limitations presently are that they're not quite sure what metabolites to look at. Still very expensive, very time consuming, but maybe in the future they'll be able to decide what metabolites have the highest sensitivity and specificity for prostate cancer tissue, and maybe incorporate this into the MRI sequences for multiparametric MRIs. It's also the question of, rather than manually positioning the biopsies during a transperineal biopsy, to actually use a robotic control to do this. And to achieve this, you've got to register using the MRI or ultrasound where all the tumors are, and then the robot is supposed to be able to go around and pick out the tumors. Again, these are all experimental and not yet in clinical use. And then clinical trials that are looking at how well MRI performs, how much we can rely on the MRIs, whether or not it's going to be able to, like we said earlier, rule out the need for a biopsy. These are all unknowns. So there's a PROMISE trial that's looking at biopsy-naive men to see whether or not a biopsy can be avoided in some men if they have a normal MRI. Still in progress. And the PICTURE trial is comparing MRI findings with transperineal biopsy findings to try and see again whether or not MRI can detect lesions that will be detected with template biopsies, and therefore avoid having these men go through the procedure. I'd like to acknowledge Mr. Derek Rosario, one of the PIs on the PROTECT study, for sharing some data with me, and also Dr. Emily Pang for allowing me to use some of her slides as well. Thank you.